All right. Good morning. Looks like everybody has just about got through the waiting room, so I'll go ahead and get started with a few intro things, and then we'll turn it over to Alex for his presentation today on infectious disease and substance use disorder. This is actually a second part of a talk that Alex has put together. If you missed the first part, no problem. You'll still be able to follow along. But if you want to catch the first half, you can do that through the recording of the training, which is posted on our Project Echo webpage. And I'll drop a link to that webpage here in the chat once I get through this stuff here. So, yep, we are obligated to just state here that there are no financial relationships to disclose for all those involved in this project today. And then our funding statement, we're a grant-funded project funded by the State Opioid Response Grant from SAMHSA that comes to us by way of Nebraska DHHS. Okay, so if there's anyone new today, Project Echo is what we are here today. This is the Nebraska Medical Association's Project Echo on substance use disorders and pain. ECHO stands for Extension for Community Health Outcomes. So you can have an echo on a variety of topics. Ours is on, as I said, substance use disorders and pain. The heart of what we do are these Friday morning trainings. We do these in groups of four. So we've got four trainings over the course of the next 2 months. Then we'll be off for a month, and then we will come back with another set of four new trainings on a variety of topics within the realm of substance use disorders and pain. We've got a hub team of 6 experts, and those 6 experts are available for consultations outside of these trainings. We also do other trainings, in-person trainings, smaller group, larger group trainings outside of these Friday trainings. For example, John, our pain expert, is on his way up to St. Mary's College to give a talk on pain to the PA students. So, if there's a group and we can get someone out there, get in touch with me and we can see if we can make something like that happen. All right, so here's our current series that we're working on right now. This is the first one. After this one in 2 weeks, Todd will be on with that's actually over there. That should be the patient experience of SUD. Apologize for that. And then we've got Ed doing injectable buprenorphine and naltrexone, and then Stephanie discussing psychosocial challenges with SUD treatment. It's same process for CME certificate. I think most people here are probably familiar with that, but if you're new, there'll be just a quick evaluation survey that will be dropped in the chat and also come to your email. If you don't see it in your email, check your junk or spam folder. So you just complete that brief evaluation survey, and then you will have access to that that training certificate. There is a new little wrinkle here. This third bullet here. So after you complete the survey, instead of the survey popping up automatically, you'll have to go back to your email that you gave in that survey, and there you will find a link to your certificate. So one little extra step. We've kind of changed our process and the way our certificates look. But if anyone has any trouble, just shoot me an email. It should be pretty easy. All right. So, like I said, we've got 6 experts on our team. I'm going to stop sharing and I'm going to let our team introduce themselves. Let's see. Mary, would you like to go first?
Sure. Hi, I'm Mary Ellis. I am an attorney and a nurse practitioner here in the Omaha and surrounding community areas, and I work a lot with families and criminal law as well as in the medical community.
Thank you. Stephanie.
Hi, everyone. I'm Stephanie Bennington, a psychiatrist located in the kind of Chadron and Rapid City area. It's really great to see you all this morning.
Thanks. And Todd.
Good morning, Todd Stull. I am a psychiatrist and located in the Lincoln area.
Thank you. And John, are you able to hop on quick and introduce yourself?
Yeah.
Okay.
Hi, good morning, everybody. John Massey. I'm a pain physician and I'm located in Lincoln. Good morning.
Good morning. And I got a text from Ed Kaiser, nurse practitioner who practices substance use medicine. He is going to be 10 minutes late, so I'll just put a plug in for him. And then, Alex, I'll turn it over to you and let you take it from here.
Thanks a lot, Will. I'm Alex Dworak. I'm a family physician who works in Omaha and underserved medicine. I'm currently on vacation, so apologies for the hotel Wi-Fi. I think we've got it sorted out after I moved around the building, and Will has a copy of my slides in case anything goes sideways with that. So let me get my screen shared here, um, and there we go. Okay. All right, so here's my subtle note to myself of where I got last time. And again, the Zoom is there. I can send a copy of my slides. I know that at least one person was asking for it. I sent that to Will. That didn't go through last night. Apparently went through just now. Yay, hotel Wi-Fi. So we talked about hepatitis and HIV last time. I'm going to talk more about, and we also got to syphilis. I'm going to talk about some bacterial complications and then some harm reduction efforts. And this is all stuff that I've seen at some point, although the references are here. I just tried to put together something helpful to go over some of the things that I've run into. Cutaneous manifestations of injecting drugs. Obviously, you can get cellulitis. Abscesses are pretty common. Necrotizing fasciitis would be one of the more fearsome complications that can happen. People may call it skin popping or intramuscular. I haven't seen that as much. People who use performance-enhancing drugs will call it pinning a lot. But again, you may see that people will start with the easy veins and then progress to move on to more challenge to either muscles or feet or other areas, just as they keep trying to find a way to get into the vein. Per this citation, women may have smaller veins. I know I have had that with some of my patients who've used drugs who are a very hard stick, where we got to send them to the hospital to get one of the very experienced phlebotomists to get a blood draw. I haven't had a lot of patients talk about trying to get a slower effect. A lot of times people want to get the drug into the central nervous system as quickly as possible to either get a high or to just get the effect so they stop feeling sick. But that's another thing that's mentioned here. So a lot of this can happen because needles aren't sterile or because they are being shared. And if you have injection of cocaine or methamphetamine would do this too, or xylazine, which is a tranquilizer, all of these can have additive psychoactive effects. You can get some local effects because of vasoconstriction from some of those substances that are different from the opioid itself. And as always with recreational drugs that are bought illicitly, who knows what you're getting? It's probably fentanyl, but if there's other things added to it like xylazine, that can be part of why you get some of the skin ulcers and stuff. And then both drawing some blood in first and then injecting it back, or I have read in some, not as much in the United States, about the flash blood idea of giving somebody else your syringe with some of your blood in it and they inject that. That may be placebo versus a small amount of the drug if somebody doesn't have enough money to get their own drugs. But obviously, that is a risk for bloodborne infections, as you would imagine. People who are malnourished can have that as well, or higher risk of bacterial infections. I did see some things about some immunosuppression just from injecting drugs, even in the absence of HIV. And also, if somebody is having a severe drug problem, they're probably not paying the best attention to their nutrition. And so that's a setup for your immune system not working as well, too. Clearly, if somebody has untreated HIV or especially advanced HIV, that is a problem. Somebody who is injecting drugs but also taking their HIV meds, which can happen, and for the record, active drug use should not be a reason to deny people things like HIV treatment, can also raise your risk of problems. And if somebody also happens to have diabetes, which I have seen, probably if you have a severe drug problem, you're not taking the best care of your diabetes. And then that leads to, more potential issues too. So, um, all right. So let me get this chat window out here. Okay. And not just the skin, as you might imagine, if somebody's not cleaning the skin, but or the contaminated needles, but saliva. The first time I had a patient who admitted to licking his needles, I was like, what? And so I've got a slide about that. But Staph aureus, as you may imagine, common skin and oral pharyngeal pathogen, and commensal. Strep pyogenes, and then you can get some of the, the Eikenella, like and these other organisms here. Tetanus and botulism are possible. And then some other Clostridia and Bacillus, including Bacillus anthracis, are less common but plausible. So you need to keep a wide differential. And ideally, if you think somebody may have something bad going on, get them to the hospital if they're sick. But a lot of times people are not that eager to go seek additional medical care. Many times these things happen outside of medical supervision, and they only show up if things are really, really bad. And when they do get there, we need to make sure that if they're in the hospital, we are addressing their opioid debt and trying to help them not be in withdrawal, or they're probably going to leave AMA. So. And again, when I first saw this, I was like, why would somebody do that? This citation mentions a ritual, the idea of cleaning the needle, although obviously we know as medical people that does not make it clean. That makes it very dirty. Enjoying the taste of the drug, there can be some associations there. Trying to check quality, tasting your dose, so to speak. In this case, literally. That can also refer to taking a small dose to assess potency, and hopefully not pass out with fentanyl. That is very plausible. And then checking to make sure the needle was in usable condition. Although, as we'll see, that if you're reusing a needle, that's not great. And so there's a policy solution that exists for that. So. But in terms of reusing needles, this was from Appalachia, and it was actually a very current study from last year. Um, and needle reuse, as you can see, is very, very prevalent in this sample. And if people are older and can't get syringes as easily, they're more likely to reuse them. That makes sense. And if they're closer to a syringe service program or a pharmacy, then they do this less. And this is a good thing. So, and again, we'll come back to this at the end with an NMA supported initiative. So, and there's a few different pictures out there of what needles look like when they're reused. I remember seeing this at an HIV conference in Denver, I think over 10 years ago, that one of my HIV mentors sent me to. But you can see that the needle starts to degrade. There are more barbs, and as you might imagine, both with more contact with the outside world, the needle maybe not being kept in sterile conditions or being like re-irradiated or anything like that, like a fresh one would be. And just look at the surface area here as the metal gets more warped. There's so many more areas for different bacteria to hide in. If there's still blood on it, that's back a little petri dish. And so this is for me, this really drives home like, wow, we should try to help people get new clean needles because just imagine how much stuff could be living on there, and then we're injecting that directly into the bloodstream. So yeah. And then again, coming back to these skin infections before we go to talk about some of the more systemic issues. Obviously, your cardinal signs of inflammation, tumor, rubor, calor, and dolor, if you're into the whole Latin thing. Uh, and again, for people who've accessed their veins a lot, this might be a little bit atypical. And so again, maintaining a high index of suspicion is important. Lymphedema, skin discoloration and scarring or track marks. And again, apart from just skin breakdown, you can have bullae like fluid-filled lesions. They can be filled with blood or just fluid. Skin crepitus, and then fever, obviously. Uh, People may be quite ill and not necessarily amount to fever, depending on what else they have going on. But if you know somebody injects drugs and they have a fever, we should be pretty suspicious and ideally trying to get them where they can get blood cultures. And again, most of the time that's going to require hospitalization. These folks, if they do seek medical care, may not be, that can be hard to set up. We should take every opportunity to get these people access to care because each opportunity missed can lead to a lot of morbidity. People can, come back very sick or they can die. So. And again, the antecubital fossa of the non-dominant arm, because you're injecting with your dominant hand, would be a commonplace. And then people may use the veins on their hands, their feet, anywhere they can get to. If somebody's injecting in their jugular or femoral veins, you may have some cutaneous infections in unusual places. And like we said, Staph aureus is the most common cause of abscesses, although there can be lots of things. And if somebody is licking their needle or it's not sterile, the differential is broad. And if you have polymicrobial or anaerobic abscesses, if you've never smelled anaerobes in a human body, you're lucky, but you won't forget it when you do. And then group A strep, Staph aureus for cellulitis. Most of the time, MRSA is more likely to be purulent and more typical of an abscess. You're going to want to cover for both of these if somebody comes to your clinic and you can if you can get a culture going, great. But you should again, it could be either of these things or both. And skin ulcers, they need good wound care. Even in Omaha, good wound care is hard to get for me. And skin grafting may be necessary. That's going to be a challenge too. And just getting somebody to where they can access that care is important. They need to have insurance, which currently Medicaid is accessible to people who have severe drug problems in Nebraska. We will see what happens with that as Medicaid changes are upcoming. And uh, you can try to bring them back regularly to do as much local wound care as you can. Talk to your local or regional experts for help with that, and then try to get into plastics. But the key to this is you have to treat their substance use disorder. If we're just trying to fix the complications but not addressing the underlying cause and giving somebody access to medication-assisted treatment, good luck. Like this is going to be futile. Uh, I've seen patients who've had like they're on their third heart valve from tricuspid endocarditis from injecting. You got to treat the drug problem. Otherwise, even if you get them through this acute crisis, the same thing or other things are going to keep happening. So. And then necrotizing fasciitis, again, this is a medical emergency and a surgical emergency. They need IV antibiotics and an emergency surgery consultation. So if you suspect this, you have to get somebody to the hospital. This cannot be managed outpatient. They could lose their arm or they could die. So. And then again, some rare things I have not. Well, I've seen some fungemia, but again, Clostridium botulinum or botulism, cranial nerve paralysis is somebody. If you know somebody injects drugs or that you suspect from their appearance and they have any kind of neurologic deficits, again, they need to be in the hospital. They need to be blood cultured, get some imaging, talk to infectious disease. But again, if they're having cranial nerve paralysis or progressive paralysis. Botulism can do that. And apart from like improperly canned foods, again, I didn't realize until I got this talk ready that you can get that from injecting, but you can. Tetanus, it's another thing that, depending on how things go with vaccination in the United States, we're already seeing measles in, I think, over 30 states if I remember correctly, but we may well see more tetanus if people are not immune to that. And then fungal infections, candidemia. These are more common in people who are immune compromised and not using drugs, just I mean, from what I've seen. But an important point is if someone is candidemic, we need to get them to an ophthalmologist to look for candidal endophthalmitis. So any candida in your blood cultures should have opto as well as infectious disease consulted. Again, this all presumes that this person is hospitalizable. And again, that's not going to happen if we're not treating their drug issue, like they're going to leave AMA. So we keep coming back to medication-assisted treatments, talking to your pain team, your addiction team, or trying to get them to someplace that has that, is important. You may need to use, frankly, obscene doses of morphine if somebody is not already on medication-assisted treatment. We had one patient who I think was getting 600 milligrams a day when he was in for infectious discitis, but it was controlling his pain, and he was staying for his antibiotics and not leaving AMA like he had the last time. So again, it's all about balancing harms and benefits. Did we have him on pulse ox and have some Narcan? Yes, we did. But did we load him up to where he was comfortable and not withdrawing and not wanting to leave? Yes. So. And then heart valve, endocarditis, typically tricuspid lesions, and we'll talk about those manifestations in a second. Obviously, HIV/AIDS, other chronic and bloodborne infections like hepatitis C and Hep B, like we've talked about in the last half of this or the previous half of this talk. So, and then again, pyomyositis, pus and inflammation in the muscles. tetanus, botulism, venous insufficiency due to repeated vein injuries. So what might look like venous stasis ulcers that we'll see on the legs, but happening in other areas. Gangrene where tissues are just dying, sepsis, amputation, chronic pain. If somebody doesn't already have a chronic pain disorder, which, as we know very well, is quite commonly coexisting with drug problems, they can get one. And then the stigma of having chronic wounds that can be devastating to people. I mean, and literally very stigmatizing. It's obvious that you're in poor health, and probably obvious to most people that you are using drugs. People may identify themselves as a junkie, a very negative self-image, and again, that makes it even harder to get back to a place where they can feel good about themselves, have the motivation and the capacity to want to get healthy and to try to, make improvements. It can be a vicious circle. And then endocarditis and septic emboli, which, again, anybody who has active bloodborne infection that has new, signs of, peripheral occlusion or new neurologic deficits, you have to presume that that may be a septic embolus that's gone to the brain or gone to other parts of the body and blocked off the peripheral circulation, and of course, death. So. So what do we do with all this? Again, so obviously help people get into mats, get into recovery. But for the people who will be out there who are not ready yet, uh, get them clean needles and have syringe exchanges. Give people supplies to clean their skin before they inject. Encourage hand hygiene. Try to help them have access to basic housing and things like that. And then again, getting people into treatment. There's a lot of evidence that syringe exchange programs not only reduce infectious complications, that is well proven and not debated at all, but they're also a place where people come into contact with someone who gives a damn about them. One of the other testifiers who spoke about the bill I'm going to reference when I was representing the NMA for that said that he was using hundreds of milligrams a day of OxyContin. A lot of friends of his died. He made it through, but he said, if I had talked to somebody who gave a shit about me, pardon the language, that's what he said, I might have gotten my life to, I might have been able to get out of this sooner. And he's now an advocate and an evangelist to try to help other people so that less people die and people don't go through what he went through. So. Okay, and then here's some pictures again from this wonderful Kiwi site, which is great for lots of other things too. I reference it a lot with my residents and med students. Cellulitis, of course, you've got your not, you're sometimes a bit vaguely demarcated. I mean, this is fairly clear with again your redness, your warmth, your swelling, and your pain. And then necrotizing fasciitis, again, that's obviously quite severe. And again, that's a surgical emergency. You may need fasciotomy and debridement of devitalized tissue, or that person's going to die. So, and then here's a cutaneous abscess here. So, and then uh, just highlighting, I think this one was from 2022. Uh, Trying to reduce overdoses is important with Narcan. Again, access to treatment, reducing bloodborne infections, and we're going to talk about treatment as prevention. But this just highlights that this has been an ongoing issue that's been getting worse recently. Then, in terms of harm reduction, again, we want to have a multi-layered approach. Kind of the Swiss cheese idea of like, we don't just want to put all our eggs in one basket. We want to have public awareness. We want to have needle exchange programs. We want to have counseling. We want to have access to treatment. Thank you all so much for being here and for wanting to learn about these things because it's us. Like, we have to be self-rescuing damsels. There's nobody coming in to save us, especially not now with the federal government doing what it's doing. This has to be something that local communities and local practitioners and states, we're going to have to do even more of this on our own than we did before. So, but again, people, for better or worse, often don't get that sick, and they often, again, will not engage in medical care. This is a golden opportunity when somebody does seek care for us to try to retain them. And so every chance we get, it's important for us to try to take that. I know for me, I had a lot of stigma and bias kind of built in about those people, and what just having negative views of them that were passive and happening without my conscious awareness. my medical training did reinforce those, unfortunately, and so I've had to try to deal with that and break it down and come back to how do I help this person who's suffering. So if you're like me and you have some of that from your training or your upbringing, it's important to try to recognize it and consciously overcome it by putting it to the side and saying, this person is sick and they need help. Not this person is a junkie or this person, is an addict or this person is, trying to score or whatever, but like this is a person with a severe disease who needs my help and I have a chance to help them and I have the tools to help them. So, um, and again, if you have one of these more severe infections, especially a bloodborne bacterial infection, hospitalization and prolonged IV antibiotics, this is an automatic infectious disease consult. You'll be wanting to get an echo, at least a TTE, maybe a transesophageal with cardiology's help to get a good look at the heart valves, have cultures. This is a huge process. And obviously, somebody who may not have been doing the greatest, like maybe they've been able to work, maybe not, but they're going to be out for weeks. And so this is very disruptive to that person's life and to their family life. If they, have not already lost that because of their substance use problem, it's hugely costly. They're not productive and like contributing, for themselves and for their community and their family. Obviously, prevention is better, but when this happens, like we need to use a lot of resources. And if we don't get people access to, medication, the same things will keep happening, and it's just pouring money and resources and consults and everything, and things aren't getting better. So again, just trying to, you know, handle complications as they come up, but also get people treatment so that they stop being at risk of this, ideally. So, okay. And again, another thing from Australia, actually. Just highlighting that if people do have these issues, they're at high risk of incomplete treatment due to leaving AMA or to poor engagement with medical care. Many times these people have had lots of bad interactions with the medical system because, somebody like me, may have treated them badly, kind of yelled at them in the hospital and made them feel ashamed. They may come kind of primed and pre-loaded with a lot of stuff that just being in the hospital or around the medical system may trigger. It's important to remember that that's in the room with you, even if you personally have nothing to do with it. Uh, I see this with lots of other underserved groups where people who've been treated like crap expect to be treated like crap, and they behave in ways that provoke responses from us, consciously or not. And then they have another bad experience, and then that just perpetuates the whole cycle. So, again, doing your best to be compassionate, as we always are called to be as medical professionals, but also, again, just know that this could be in the room with you, even though you didn't bring it in there and you had nothing to do with it. Trying hard to step back and not take it personally when traumatized people and people with personality disorders and other things that may lead them to be at higher risk of drug use or like untreated ADHD with impulsivity and just knowing that that's part of their neurological makeup, their life history. You didn't do it, but you have a chance to not be another brick in the wall, to offer them a pathway to getting healthier. They may or may not take it, and that's hard too. I remember talking with one of my PAs when we started our Suboxone program. It was just two of us. Now it's eight, I think, in our clinic. And we were like, one of our patients is going to die eventually. Even though we're going to try as hard as we can, we're going to do everything we can, we're going to lose somebody. That goes for everything in medicine. And Years later, like we've helped so many people and prevented so many deaths, that we can easily feel that it's worth it. But I mean, we do have to grapple with that. We're not going to be able to help everybody. That doesn't mean that, but it's still worth it. And it's still important to try to help as many people as we can. So, and again, just this was highlighting in Australia where they use methadone. If you are adequately treating somebody's opioid disorder, their opioid debt, so to speak, like however much they were using before they came in the hospital, if you just stop it, they're going to go into withdrawal. You got to load them up with enough opioid to where they're not in withdrawal so they can stay and be in treatment. And Again, if they are having untreated pain from the infection itself or just because of withdrawal, stigma, discrimination, social stresses where their social life is probably not amazing before they go in the hospital, or policies that may be unhelpful, that's going to lead to people leaving AMA and then either dying or coming back, even worse. So, and if you are seeing this in your hospital systems, trying to be a change agent and say like, let's focus on the outcome of the patient getting healthier what can we do, to try to make it so the patients can, stay, get their pain treated, and get the antibiotics that they need, get the social support offered to them, and hopefully do better. Yeah, and then again, endocarditis. I think we're just a little bit over 30 minutes, and I want to leave some time for questions. A lot of the time they're going to be Staph aureus, but again, your skin flora and then enterococci can happen too. And then you've got your Hayseck organisms. Oral flora more common if someone's licking their needles, as we've talked about. And fungal endocarditis, more common in like, the oncology setting, but again, can be severe and fatal. And then again, immunosuppression, which can happen just from the drugs, if not from diabetes and other things. Poor dentition is another thing. If you have a severe drug problem, you're probably not going to the dentist very often, and that's presuming you even have access to dental care. Many patients do not have any dental coverage, and so that's a big problem in Nebraska and Iowa, like at least around the Omaha area, I can attest. Uh, and then if you have any congenital or acquired valve issues from prior infections or rheumatic heart disease, or especially if you have like a prosthetic valve or something, obviously all those things are going to anything that makes it easier for bacteria to kind of grab onto your valves is going to increase your risk of having problems. And then again, a lot of times uh, tricuspid endocarditis, if you see somebody who has that and you don't know they're using drugs until proven otherwise. Like tricuspid endocarditis is just a big, big, big bat signal that says, ask this person compassionately and non-confrontationally, like, hey, are you have anything going in your bloodstream? Are you injecting? Because that again, I've seen people who are on their third valve, and the surgeons are like, we can't keep operating. Like, this is too traumatic for the tissue, and I also, like, we need to address the underlying problem, and hopefully the patient is going to be agreeable to letting us do that. So then just a brief review of what you'll see. Again, fever, chills, sweats, your constitutional symptoms, headache, exertional shortness of breath. But you can see a lot of these are fairly non-specific. If you know somebody injects drugs, you can be thinking about this. But again, they may not admit it because of shame and stigma. If you're seeing petechiae, and again, darker complected individuals, this may be less obvious. Splinter hemorrhages running under the nails. Osler nodes are painful. Janeway lesions are painless. And then loss of appetite, weight loss. Again, if somebody is in care, a lot of times people aren't in care for us to appreciate these things. So then here's something for my fellow Trekkies here. That's Captain Janeway, if you're not a nerd. So. And here are some photos of these things. Again, just what you may see with the Osler nodes, the Janeway lesions, and then some other skin manifestations here. Again, having a high index of suspicion if you know somebody injects drugs. If you're seeing these things, you're going to want to try to get them to the ER, get blood cultures going. They may or may not be game for it, but again, take every opportunity you can to try to get somebody help when they do present to care. Then osteomyelitis coming around the horn to wrap up the infectious complications. Infectious discitis can happen. And again, not all discitis is drug use, but you should be, asking, carefully and, non-confrontationally, like, hey, is this part of what's going on here? You can also think about alcohol use disorders as being an immunocompromising thing and looking for diabetes and HIV screening and stuff. But back pain or other bone pain, and then when you're diagnosing that, you're going to want to try to get tissue sampling with your interventional or surgical specialists. We often get plain films initially, but MRI is the modality of choice. And then you're going to want to try to initially get them on parenteral antibiotics. I think you should be consulting infectious disease, like that's what I have done in my career. But there's some comment here on following on with oral treatments. But again, why would you not have infectious disease co-manage this with you? So then CNS abscesses are mentioned too. Paraspinal, epidural, and brain abscesses can happen, interestingly, without infectious endocarditis. Although if somebody does have it, those septic emboli are something that are a fearsome complication. And then again, just this article also mentions tetanus and botulism can happen too. And like I've been saying, high index of suspicion. if this person happens to seek medical care. I mean, we hope they do, but a lot of times people are not accessing the care system the way we would like, even in the best, if they have insurance and have the ability to do so. Okay, and then just another piece of evidence here that treating somebody's opioid use disorder shockingly improves their retention and care. I mean, I think we know this from if we've done this treatment, but if we're trying to if somebody has one of these complications, they're already in big trouble. Like these are not that common, and so somebody has gotten a very bad complication of this. If we're not treating their drug problem, it's not going to work. And so we need to and again, this is not just my opinion. This is backed up by this and other pieces of evidence. So try to make sure we're offering that. Get your pain team, get your addiction team if you have that to help you, and they should be on board with it. If they're like, no, we don't want to do that, that's the wrong answer. So. Okay, and then again, getting back to the multi-layered prevention and treatment strategy, syringe exchange programs help. So, and again, stop injecting, yes, obviously, but we will have people who are not ready for that yet. And so helping them be safer until they are ready for help and not stigmatizing them and, uh, discriminating against them and, making things worse is the right thing to do. So this is from the CDC. I've downloaded this before. Recent leadership changes at CDC, so we'll see if this is still there, in the coming months and years. But again, we have most of my lifetime that shows that they're safe, they're effective, they save money, they do not increase illegal drug use, they do not increase crime, and they're important for preventing and treating, by getting people a pathway to treatment viral hepatitis, HIV, other infections. And again, we have politicians who have said the exact opposite of all these things, uh, which frustrates me to no end. This is hard enough as it is. It's even worse when we have people repeating disinformation and false statements. I think probably due to bias and stigma. But again, the facts are the facts. So, and again, if you get people into the syringe programs, they're a lot more likely to enter treatment, just like that testifier I mentioned. They're more likely to stop using drugs. Not all of them will, but they're going to be in treatment. They're going to be safer. There's going to be less transmission of other infections. People have a better chance of getting their life back. And again, if they're also going to be getting Narcan through this, they're less likely to die. We like people not dying. That's what we're all about here. And also there are less dirty needles for like EMTs, police, the fire squad and everybody, and community members to maybe stumble on and have a chance of getting an inadvertent stick. So again, this is from the American Academy of HIV Medicine, of which I happen to be a member. Sharing paraphernalia is bad. We know that. And uh, making it easier to get clean syringes, like the fewer barriers there are, the better things are going to go. So, okay. And then this is just some more, again, reduce overdoses. There's a lot of research. Again, this is not controversial. So, then here's Nebraska's statute that has been proposed. It wasn't debated this year that I was aware of. It should be coming up next year. Testimony has already happened, but if and when that happens, if you are moved to contact your elected official and encourage them to approve this, this was approved and then was vetoed in 2024. It was incredibly frustrating. This should be a nonpartisan, all around win for Nebraskans and really in any state. So, and again, this is the current legislation. Again, testimony has happened, but this should come up in 2026. Again, this is something that affects urban areas, that affects rural areas. It affects minorities more, but it affects everyone. This should be a slam dunk to improve uh, that the health of Nebraskans, both the people that directly receive services and others who are less likely to suffer complications, from inadvertent exposure. I mean, again, just it should be not a controversial thing at all, in my opinion. So, and again, treatment as prevention is kind of an HIV-based concept, but the people who have some of these things are the ones who are most likely to spread them. They should be a high priority to get treatment. And again, like I feel like a broken record, but um, public awareness, access to primary care, access to dental care, syringe programs, medication assisted treatment. Like these things all go together to combat this. And this was talking about microelimination of viral hepatitis, but I mean all of these nasty things that happen from injection drug use are going to be better if we have these multiple interventions working together. Yeah, and then again, it's broken record. The best evidence-based treatment is opioid agonist therapy, medications as a treatment. And syringe programs are also, have a lot of evidence, and even in this citation here, that they're helpful. So, and again, people who inject drugs are marginalized in a lot of ways. They are at much higher risk for a lot of these things. It's super expensive, and bad. Like even if we care about nothing but money, this is a slam dunk, putting aside the human suffering involved. So, and again, if we can get somebody into care, if they have hepatitis C, we can, nuke it. Like it's very, very, very treatable. And again, we can also get somebody's depression and anxiety managed. We can try to, get them their cancer screenings, all the things. Just getting people into medical care and linked and retained is the way to go. So, and the people who are in the biggest trouble are the ones who are probably our best and top targets for this, because that's where a lot of the both the cost savings and the reduction in human suffering can happen if we can reach them. Okay. So I didn't leave quite as much time for questions as I might have liked, but here is a picture of an Einstein ring with gravitational lensing because astronomy is cool. I will stop talking and have even more caffeine than what I've already obviously had, and look at the chat here and see if anybody has any questions.
Thanks, Alex. Yeah, feel free to drop questions in the chat. We've got time. If you've got a patient case, feel free to drop that in the chat or unmute and speak up. You got an amen from Latrice. I'll second that amen. You always do a good job of speaking about these things with compassion and without stigma. So thank you. Um, just pause here and see if we have any questions. Feel free to drop those.
As my Cuban Spanish teacher used to say, silencio absoluto, absolute silence.
Well, we can give it another minute or two, see if anybody has any questions. I'm not seeing any.
Well, and in the spirit of evangelizing, I will say that the Nebraska bill is a bit different in that it promotes local control and municipalities having their own programs. It's not a one size fits all. But live long and prosper, and long life to you. If this does get approved, it will be local health boards and each community will be deciding if they want to do it. It's not mandatory, and towns may buy into this disinformation and say like, no, we're not doing that because we don't want, more of those dirty people, even if they're not saying it quite that much. It's like, okay, we know that's what's meant there, but it may be well. Again, I hope that goes through because for all the evidence I presented here. But it will be on us as clinicians across Nebraska to step up and be champions for this and to say like, okay, how is law enforcement and the local health community going to enact this in the municipality you're in? If this does go through, I'll put this out there as a call to prayer, a call to action. prayer as making positive change in the physical world by partnering with your local community to help write guidelines, help make that happen. This is, this has been done. There's a lot of stuff out there. Dr. Balasanova, another NMA member, has worked very hard on promoting this for years. She and I and lots of other people in the infectious disease and infectious psychiatry worlds would love to help. So if we do get this bill as an option and your small town is considering this, don't be bashful, reach out to us. You don't have to reinvent the wheel. It's out there with how to do this and how to do it safely. And it wouldn't have to be like you putting in a huge amount of time and effort to write it on your own. So,
Alex, I got a direct message from Mary Ellis, one of the members of our team, wondering about if you could talk about treating meth sores. If that's something you see and do. Yeah.
yeah, I mean, a lot of the principles are going to be the same as your standard wound care, which again, even for me in Omaha, it's hard to get people to wound specialists. You're going to obviously try to address other issues, and for meth in particular, I keep checking on things. I have seen some documentation of bupropion and naltrexone being possibilities to help with that. And so I actually have somebody at the HIV clinic who's being referred to me where that's my planned offer. And also, you need to be cautious. There is not amphetamine substitute or assisted treatment that's been FDA approved. But if you're talking to somebody and it's obvious that they have severe ADHD, we do have things like lisdexamfetamine or Vyvanse, which is a prodrug that if you crush it and snort it, nothing's going to happen. And I think you can cautiously consider documenting that they have both a drug problem and ADHD. Substance use disorders are a contraindication in the package inserts. So I think that is something where you'd have to document very clearly. I am considering the harms and the benefits of this, and and be very spell that out very carefully. But I mean, if somebody tries to misuse Vyvanse, or lisdexamfetamine compared to meth, and I think, just counseling your patient, trying to be compassionate with them. If they also have an opioid problem, again, buprenorphine does not treat meth. But if they have an opioid problem and a meth problem, you can at least treat one of those, and then the patient, hopefully has a little more bandwidth to, get their life to a better spot. There's a lot of ongoing research there. I'm sure my psychiatry colleagues could probably speak to that better than me. Things like contingency managements, where patients get paid to have less substances in their urine. That's a promising area, but it's very hard. I know that in Australia there was a study that I believe was going on looking at medication-assisted treatment with amphetamines, but I don't think that, again, that's not FDA approved at this point, and so we're really kind of in a pickle with that. So you're going to want to treat the skin infection, as best you can, and ideally get them to a wound specialist. But your average person who has skin ulcer from injecting meth is probably going to have a hard time navigating the system and getting to consults, to be honest. So it's I don't want to sugarcoat it. It's very challenging.
Well, I'm not seeing any questions. I did put a link to the evaluation survey in the chat. You're welcome to grab that link now and do that real quick. That link will also be coming in an email. And then just a reminder, the process is a little different. After you complete that survey, you'll have to go back to your email. You'll give an email in that survey. Go back to the email you gave in that survey, and then in that email will be a link to your CME certificate for today's talk from Alex. And yeah, thank you, Alex, for joining us. Even while you're on vacation, we'll let you get back to your family trip. And we'll be back in 2 weeks. We'll be doing something a little bit different in 2 weeks. Todd Stoll will be leading the way on a talk called The Patient Experience of Substance Use Disorder. But really, he's bringing a patient to do, I think, most of the talking. So we're going to hear from the patient side of things next week. So looking forward to that. It'll be a little bit different. And hope to see you then. Have a good Friday, everybody.